There we go. So I think we're all used to the manual traction methods that are used for Colles reductions and the sheer manpower and time-consuming element that's associated with it. And then the majority of patients that tend to have the Colles type fractures are elderly, and then they have all the problems with kind of very friable, frail skin, and then when you're doing all these kind of like very brutal pulling techniques, you can get a lot of skin trauma from it, lots of bruising, and I've always found when I was involved in doing Colles pulls, I didn't have the physical strength to kind of hold on to a hand for any length of time. I just really physically struggled with it. So when I went to Guildford, I was working there as a practitioner a couple of years ago, and I was introduced to the finger trap technique by an orthopaedic registrar. He was Canadian, and he was a great fan of it, and so he showed me the technique. And then after that, as an ENP group at Guildford, we got some finger traps, and then the ENPs kind of took on this technique, and then we managed all of our Colles fractures using this, doing manipulation whilst they were in the traps, and then into fracture clinic for further management. So what we're saying is that it's not going to be the most perfect reduction necessarily, but it does a lot to improve position. That even if they slip a couple of weeks down the line, you've given the best possible chance for trying to improve that fracture for them. Is the best correction of doing the radial shortening. It can be a single practitioner technique, so great as soon as you identify that there is a Colles fracture that needs to be managed and fracture position improved, you can get that patient up into the traps as soon as you've got your x-rays back. Now at Guildford we used to do this reduction without using hematoma block. We had the benefits of Penthrox there, we used to use that quite a lot, and also Entonox. But there's no reason why if you want to put a hematoma block in, you can do, and then actually while they're there hanging, that hematoma block has got time to work. Lots of times you see hematoma blocks being put in and then 2 minutes later they're being pulled.
Yes.
And then of course that hematoma block has no efficacy whatsoever. Fractures are more likely to slip, they don't necessarily have the right degree of support, but it can be done.
Julie, when you say plaster, is that plaster of Paris then when you say plaster?
Plaster of Paris, yeah. So we used to use the rolls and just put, yeah. Now we also use the finger traps just to improve general fracture position. So on Smiths and Barton type fractures, where obviously you've got neurovascular compromise and you just want to improve it so they can, before they can get to theatre and orthopaedic management. So many a time we've hung them and then done a volar slab with a dorsal tilt just to try and stop that fragment from causing too much disruption from a neurovascular point of view. And it does actually give a fairly good improvement and enough to give them sort of by orthopaedics time to get them sorted. Now certainly from feedback with the patients, they all actually report using the finger traps. It does at the point that you are putting them up reduce pain for them. Because when they're sitting there, they've got a lot of pain now, they tend to be sitting like this and that wrist is very uncomfortable. Once you're hanging them up, it's kind of a bit like zero gravity really. And actually it's quite a comfortable procedure. They more get concerned about the fact that it feels quite tight around their fingers. But I think as long as you've got full compliance with them, they understand, and it's a very interactive process with them. Because the big trick is actually getting them to understand why you're doing what you're doing, and it's all about them relaxing enough to allow that traction to do the disimpaction for you. And you'll hang up the most deformed looking wrists, and within sort of 5-10 minutes you're already seeing a great improvement in losing that kind of dinner fork element to it. And I'm very passionate about it because we've had so many good successes with it. So the best thing really is to do a good demonstration now, isn't it?
Yeah. So what is the hanging time that you recommend? Half an hour?
I do half an hour.
Yeah.
Well, usually like it depends basically. You can but I used to go after 15 minutes, 20 minutes, just check if it is okay. If not, I just say we give a little bit longer, but
absolutely.
on average 20 minutes would be good enough.
It gives you time to sort of go away, get your plaster stuff ready. You usually get grabbed to do something else, don't you really?
Yeah.
And they sit there and they can have a cup of tea while you're doing this process. It can be quite a
Yeah, because they're the perforations and they're just not very clear.
Yeah, they're a bit
It's like that.
Oh, there.
Yeah.
Yeah, got it. Right, so who is going to be?
I can be.
You in there.
And now with my scrub look, I can be plastered.
Failing at the
This will
first
be
hurdle.
a bit lower than really.
I know.
Well, as you said, it can be a good temporizing measure to temporarily improve the position and probably reduce edema and pain and swelling pending surgery.
The idea behind, you are basically doing the traction, which is you need someone to counter tract. You do traction. You need to stay there at least a couple of minutes until the muscles and everything gives in, and then you can click. Sometimes you need to push. And obviously, like Jenny said, like all the skin problems with elderly people, it's painful. You're causing the additional. Here is basically just you put
Just the weight and
some
the
weight
gravity.
there,
And the gravity.
and then you just say like we will wait 15-20 minutes, and you come back again. And what you do is obviously if you're with a typical Colles fracture, because you can feel this step, but you don't come. Is there still this step there? If you are skilled like say Niels and myself or you lots, look with ultrasound. As you can see, there's no problem. Or you can do that and send it like you do normally, send the patient to X-ray. But back in Germany, we had like an image intensifier we could use ourselves. But obviously that's not
The
feasible.
advantage of ultrasound is you get the
Absolutely.
immediate feedback and about the goodness of the reduction,
That's absolutely, we do use it anyway, just like,
It's not meant to be a replacement for X-ray, but before you send them that you've done a good job.
My thing would be just with ultrasound, in order not to frighten people off, I would just put it on a small print. I would just say like, go for this method and just do whatever you would normally do to confirm the position. If the people basically normally take like X-rays like us, just send the patient to X-ray.
Now, finger traps, these are just some kind of like cheap ones that we've got in the department. The ones that we actually have, they're very nice, they're double skinned, they come in different colours, and then so you choose the colour according to the size of the finger. If you're not quite sure which size is going to fit, then I always say try it on the other side, because actually pushing these on can be a little bit uncomfortable for them. So just make sure you've got the right size finger traps. And then normally we put stockingette on first under the plaster, but it depends on what your policy is here. So if you put stockingette, put it on now before you put the finger traps on. I'll just try this size on you.
Seems to be
There we
okay.
go. Now there are some studies that say that they include the thumb in the traction as well, but actually I've always done just the index and middle fingers.
What did you use to do in Germany?
All 5.
You did 5. Oh, there you go.
But that's a long time ago, just like thumb definitely.
So
I don't know why we call them Chinese fingers. Why
Yeah.
yeah. Called Chinese fingers?
they are Chinese finger traps. I think
Yeah.
Chinese invented them.
Yeah. Yeah.
So you want to bring the kind of elbow up now, so into this kind of like 90-degree position. And so this is why armchairs are quite comfortable, because they need to have quite a straight back to maintain. If they're slumped on the trolley, it makes it quite difficult. So at this point, just make sure these are fitting quite snugly. Just sometimes for a bit of confidence, I'll just put a little bit of tape around the fingers. There's been a couple of episodes where fingers have slipped, so a little bit of tape just gives you extra security. But that feels quite snug for you? Good. And then
these 2 fingers, what I notice is that automatically goes actually, the position goes automatically. If you do the thumb, it may just pull this.
you can do it as well, yeah.
and,
Then the weights just go on the arm like this, and so they need to be hanging free, so just making sure they're not catching on sides of trolleys or on the side of the chair. So at this point now then, you're advising the patient they just need to relax the shoulder down, relax the arm, so all of the weight now is just going through those fingers, and then you can just literally just watch that wrist shape improve in front of your eyes, literally. So as an ENP group, I think they saw the success that we were having and they were quite happy for us to get on with it, and the orthopaedics were very happy for us to use that technique as well.
What do you do in terms of now? Say like I'm an 83 years old male. I was drunk
Yeah.
and then fell over and broke my wrist. What do you do for it in terms of pain relief? You said Pentrox and
Certainly,
And
if they
drugs.
were, when we used to get kind of like the 40s, the 50s, the 60-year-olds,
Yeah.
sometimes the 30s and the 20s, Penthrox was a good option for them. Now we don't have Penthrox at.
What do you do with elderly people?
Actually, quite surprisingly, some of them can cope with Entonox.
Yeah.
And if they've got a line in because they've come in via ambulance, then we'll give them some IV morphine. If they want that, or a little bit of Oromorph can be of benefit.
And
But you could, if you wanted to, you could put a hematoma block in. There's no reason why you can't do that.
No.
I say while they're hanging there, then that has a chance to be effective. So when you come to sort of doing the manipulation and the plaster.
No, we used to do, but basically definitely also hematoma, or not always, but depending basically on the patient and also the fracture itself.
Jenny, as far as the traps are concerned, they are, as you said before the camera was switched on, they're not single use, they are reusable.
They're multiple, and actually just because of the material they're made out of, from a patient hygiene point of view, you can just wash them and clean them with the wipes.
Any particular, so just wipes or what, any particular?
So I just tend
uses?
to, I tip them into the sink and then just use some soap and water, and then you can use the alcohol wipes to clean them as well. But it's a non-invasive procedure. I think you get more germs probably just sitting on a bus or sitting in a waiting room, to be honest.
Undoubtedly. Yeah.
Well, in the practical sense, do you do that? Is it obviously you can do that as a one-person method, but do you use another one, say like hold it just in position, maybe slight flexion or something?
It obviously does depend on sort of how many people that you've got on. So,
You
but
must have another
I used to
person.
do it myself. So when you're putting on the traction, the thing is that the elbow can tip backwards this way. So I used to have my leg up on a stool, and I'd use my knee to use my knee as a kind of like a counter traction, because you want the elbow to be kind of pushed this way, so the arm isn't swinging out. So if you've got nice long legs, Niels, you can use your knee and.
With
quite
stool.
You have got always like an assistant that can help you otherwise. But that would be just while you are doing basically the plaster cast.
Absolutely.
Maybe the second hand would be probably useful. Good, I'm glad. Thanks so much, Niels. Also, I've been here like over 20 years time.
Yeah.
I was always thinking, I completely forgot about it. And because
Profits are always belittled, but your time will come.
It was really good that you organized that with Jenny. That's really great.
Yeah, I think it's something that doesn't get done enough, bringing ideas from other hospitals to other places. Spilling over of ideas between trusts. It doesn't really happen as much as it should, I think.
That's really good. Thank you for that.
Thinking about this carpet.
The sheet over. You know what I'll do? I just want to put another one of those down.
There you go, look. That should be okay. Lordy Lord. Right, so I don't know, does anyone want to come up and just do the kind of counter traction on the elbow there, just for
Money?
you kind of stand round the back here. So at this point now, because obviously a lot of the swelling has gone down, a lot of the deformity, actually you're more likely to be able to, you can feel your step at this point. So it's in an ideal position really to, okay.
Yeah.
So, let's just pop this on, ready then. So plaster goes on.
But you said, you're doing like full cast.
I would normally do, yeah, I would
But
do
you're
a
doing
full,
backslap
I would
now,
do
it
a
does.
full cast, so use 2 rolls
Yeah.
and you'd be full casting at this point. And you've still got plenty of time to get that on and do your manipulation.
But you said you're using plaster of Paris, which is
The plaster of Paris
pretty
rolls, yes.
heavy for 6 weeks. Is what do they do? Or
Well, they
orthopedics,
can
are
obviously
heavy?
change it in the plastering if they feel they need
Okay,
to,
yeah,
so.
all right. Could you just do normal Scotch cast from the beginning, or
I
And
think
that's
that's
better-
very much in the realms of the plaster technicians
Yeah.
to do Scotch casting.
yeah? That's what we used to do then, Scotch casting.
But in the, during the daytime, the plaster technicians come through and you can ask them to apply the Scotch cast while you do the manipulation. Let's talk about it in there
Yeah.
now.
They're lighter, aren't they?
No,
Yeah.
much
Very
like
durable.
So this is the point now that you want to do your manipulation now, because you can either take the weight off at this point, because what you want to do is when you're doing your volar tilt, you want to kind of lift the arm up, otherwise the fingers get pushed back in the traps there. So if you just use, so I'm going to just, if you just mind that
Yeah.
hand there. So let's just take those weights off. So I always use the palms of my hands so you're not getting your fingers poked into the plaster. Use the heel of my hand and then lift up, and then, so if you now push against that elbow, and then you can bring them into the position that you want to bring them into, and then holding it in that position. This is where you need the good arm strength. You're holding it now until the plaster sets off. So the hotter your water, the better.
Okay. It's cold.
And at this point now then, you can then just take the finger traps off. And they'll always have sort of pins and needles in their fingers. Just ask them to give their fingers a little wiggle just to get the life back into them. So it's not quite set off yet, it's taking its time. And that is it. As simple as that. But you can see, just in the position that that's being held in, actually, you've got a good position of plastering there.